Does exercise prevent recurrences of low back pain? Surprisingly, the answer to this question is not an easy one to determine, but a recent Cochrane review of the literature published in 2011 attempts to do just that. The title of this review of the literature is Exercise for Prevention of Recurrences of Low Back Pain. As usual, the very prescribed, highly restrictive protocols for a Cochrane review were adhered to, guaranteeing a high-level review of the current literature. Certainly one of the key elements to a good review of the literature is keeping the research question and therefore the group of patients and studies focused. The exclusion criteria are key to this process. One obvious way to keep the conclusions specific to exercise is to eliminate studies where exercise interventions were combined with other interventions, including physiotherapy, medication use, back school, electrical modalities, and lumbar traction, among others. Although this seriously diminishes the number of studies, it does make conclusions more scientifically clean when discussing exercise intervention alone. It's also important to identify the primary outcome, which in most studies has been pain, disability, or function, and in some studies, measurement of muscle cross-sectional area. Here the researchers focused the outcome on recurrences of low back pain. Probably the first literature review with this focus. It seems that should complete the study design, but unfortunately there are still many questions that have to be answered before proceeding. First, how does one measure recurrence? The researchers chose two criteria. One, the frequency and duration of new episodes of low back pain, or two, the time between a previous episode or start of the study and the next low back pain episode. Of course, that begs the question, what's a new episode? The researchers defined this as low back pain of at least 24 hours duration, with no pain 30 days before or after the episode. A recurrence was defined as an episode of pain or absence or disability related to that pain. So, how often would you guess recurrence occurs? Well, this study confirms what's indicated in the literature from other studies. At 1.5 to 2 years, for all patients in the study, meaning the intervention and control groups, the recurrence rate was 58% with quite a broad range. At 2 to 5 year follow-up, the rate was 72%. The average number of recurrences at 1.5 to 2 years was 1.5 per person, and at 2 to 5 years was 2 per person. It was fully the intention of the researchers to then determine the type of exercise through exercise categorization. The first was relatively successful. That was to divide exercise intervention into two types based on timing of introduction. In other words, exercise intervention introduced with treatment for the low back pain episode, or exercise intervention introduced after treatment for the low back pain was completed. The next categorization was less successful. The researchers attempted to tease out the type of exercise in each study so that core strengthening, endurance, aerobics, McKenzie, high-tech versus low-tech, supervised versus unsupervised, etc., could be determined. The problem? Most studies were combinations of many types of exercise with no real clear trial of an exercise type, with perhaps the exception of McKenzie exercise, which we'll discuss later. There were only a few studies that qualified for the post-treatment group, and all of these studies had mixed prescriptions of back stretching, leg stretching, muscle contraction and relaxation exercise, and advice similar to a back school. So the results. First, the good news. For post-treatment intervention exercise, it was clear that the recurrence rate for low back pain was decreased. The number of recurrences was also decreased, and the time to recurrence was prolonged. And here's what's interesting. The post-treatment program did not influence the number of individuals on sick leave, but did decrease the number of days on sick leave. The researchers interpret this as indicating that although the number of subjects on sick leave was not different between groups, the number of days off from work was decreased in those who did exercise, which indicates a benefit for those doing exercise. The researchers used means and standard deviations for continuous data, risk ratios for dichotomous outcomes, and hazard ratios for time to event data. If you're unfamiliar with these terms, please review the video tutorial at Coffee Break Presentations on risk assessment. When we look specifically at this data, it becomes apparent that if you read any of the studies individually, you would not gain the insight provided by this review. For example, the risk ratios for all pooled data are good, but looking at the range provided by the 95% confidence intervals, it becomes apparent that although the number of subjects with recurrences is decreased for the medium-term follow-up, the risk ratio crosses 1 for long-term follow-up, which is the same as saying no difference. Looking at the time to recurrence, or stated another way, if exercise prolonged the time to recurrence, the researchers used the hazard ratio. This is the weighted risk ratio over the entire study. Here we see a strong indication for both medium and long-term follow-up because the hazard ratio and the 95% confidence intervals are below 1. We see a similar strength in the number of recurrences measured as mean differences. Here, the mean differences and 95% confidence intervals need to be below 0, which they are. The researchers go one more step to try to estimate the clinical significance, which they admit is difficult, but they calculate that the relative risk reduction is 25% for the recurrence rate and 22% for the number of recurrences. So you may have noticed I've said nothing about the treatment exercise intervention studies. Well, we need to discuss that separately. The evidence is inconclusive, but suggests that exercise given when still treating for low back pain makes no difference compared to those not given exercise. Those of you who utilize the McKenzie approach may be frustrated by this finding, but let's look closer. Remember, this is a study that was evaluating not pain reduction, but recurrences. There were only 2 studies from McKenzie that met the criteria, and each provided different conclusions. Pooled together, there was no indication of a reduction of recurrences, although the researchers do conclude there are methodological problems with both studies. Remember that McKenzie is based on a directional preference, which decreases, in particular, peripheralization of pain down the leg. As an aside, a recent randomized controlled trial comparing the McKenzie method to first-line care for acute low back pain demonstrated no advantage to the use of the McKenzie method. This was published in BMC Medicine in 2010, and look for the link to this article on the page summary for this video. So back to the studies where patients were given exercise while being treated for low back pain. You might ask what exercise was given. The studies indicated that general exercises were given by a physiotherapist. In another study, physical activity and exercises were provided, and in another, multifidus muscle exercise was given. So it's clear that there is no consistency, and likely these approaches do not match what you may use, so conclusions are therefore difficult to reach. So the conclusions for the study. The researchers conclude that certainly more studies and higher quality studies are needed, but given the current evidence, there is no indication of a benefit of reducing recurrence for those given exercise while being treated for low back pain. But there is an advantage for those who are given exercise after being treated for the low back pain for the reduction in recurrences, reduction of sick days when recurrence occurs, and a longer time between recurrences.